Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Domenica Lorusso from the Fondazione Policlinico Gemelli in Rome, Italy, and Dr. Alexandra Leary from Gustave Roussy Cancer Center in Paris, France. They will be discussing key practice-changing data for endometrial, ovarian, and cervical cancers presented at the virtual 2021 IGCS annual meeting. This episode is part of a larger educational program entitled 2021 Global Conference Coverage, an update on the clinical development across gynecologic malignancies. For more information on Dr. Lorusso and Dr. Leary, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on some new results presented at the 2021 IGCS annual meeting.
My name is Domenica Lorusso. I am Associate Professor in the Department of GYM Oncology at Fondazione Policlinico Gemelli in Rome, Italy. I'm joined today with my best friend and colleague, Dr. Alexandra Leary, who is a medical oncologist and team leader in the Department of Gynecology, Translational Research and Medicine at Gustave Roussy Center in Paris, France. Welcome, Alexandra. Today, we will be highlighting some of the case studies that were presented at the virtual IGCS 2021 annual meeting, focusing on practice-changing data for endometrial, ovarian, and cervical cancer. I will start the discussion with endometrial cancer trial, and Dr. Leary will comment on case studies on ovarian and cervical cancer. So, the first trial I want to discuss with you is the KEYNOTE-775, which is a randomized phase 3 trial comparing lenvatinib pembrolizumab versus physician choice chemotherapy between doxorubicin and weekly paclitaxel in patients with advanced metastatic and recurrent endometrial cancer. The main trial results were already presented, and the experimental combination was better than chemotherapy in terms of progression-free and overall survival, but during IGCS, the subgroup analysis of MMRD patients were presented, and also in this case, the trial confirmed the benefit of the lenvatinib-pembro combination with respect to physician choice chemotherapy in terms of median PFS, which increased from 3.7 to 10.7, but also overall survival increased from 8.6 months from the chemotherapy arm to not reach for the experimental arm. On the same way, also overall response rate was increased in the experimental combination from 12.3% to 40%, and also was the median duration of response, which increased from about 4 months to not reached in the experimental combination. Again, also in this case, toxicity is a key point of the lenvatinib-pembro combination, with about 64% of patients requiring dose reduction because of treatment-related adverse events, and about 40% of patients requiring discontinuation of the experimental arm, which is a key point in this population. What are the most frequently adverse events? Hypothyroidism in about 70% of patients, followed by hypertension, diarrhea, and nausea. The second trial I want to address is the GARNET trial. The GARNET trial is a large phase 1 trial involving more than 1,700 patients. In particular, the trial addressed the role of anti-PD-1 inhibitor dostarlimab in patients with advanced endometrial cancer who have received no more than 2 previous chemotherapy lines. What has been presented during the IGCS is the combined analysis of cohort A, The two cohorts were represented by 129 patients with MMRD tumor and 161 patients with MMRP tumor. And again, the results were absolutely interesting because response rate was quite high in both the cohort, but very interesting to me, while the percentage of response seems to be not influenced by the number of previous line of treatment in the MMRP cohort. Response rate was quite similar, about 40%. It seems that the number of prior line of therapy influences responses in MMRD patient, and in fact responses increases by from 36% in patients who have received up to 2 prior line of treatment to 50% in patients who have received only 1 prior line of therapy. And this is a great suggestion for us when using this drug in clinical practice. And dostarlimab confirmed is a very fine, I would say, toxicity profile, with only 16% of patients reported more than grade 3 treatment-related adverse events, and only 5% of patients experience treatment discontinuation due to adverse events. So the more frequent adverse events with this drug were fatigue, diarrhea, and nausea, but in most cases we are talking about grade 1, 2 adverse event, and you know that FDA approved this drug in August 2021 for adult patients with MMRD recurrent or advanced solid tumor at the beginning of 2021. Also, EMA approved the drug. The last trial is a TOTEM trial, which is very interesting trial from my point of view because it basically compares two kinds of follow-up, intensive or minimalist, in patients with endometrial cancer. In each cohort, the patients were split according to the high risk feature or low risk feature, and the primary endpoint of the trial was overall survival. Of note, and this is a key point that we will address during discussion with Alexandra, most cases enrolled in the trial were low grade and low risk patients. 60% of them were stage 1A, grade 1 to tumor, and this probably will impact on the interpretation of data. According to the trial, there were no difference in terms of overall survival for the population, either if they receive a minimalist or intensive follow-up, no difference even when considering only low risk and high risk patients, and the same was for recurrent-free survival. Very interesting to me. Also in this population, the vaginal cuff recurrence were present in 60% of patients, and this is a huge number according to the surgical experience of our colleagues. Very interesting, and this will impact in clinical practice. Ultrasound, pap smear, and CA-125 were not useful in diagnosis of relapse. This is something that should be taken in consideration. No difference in quality of life for our patient, and I think that this trial will change clinical practice. Do you agree, Alexandra?
Absolutely. And it seems like such a simple question that what is the most appropriate follow-up for our patients with endometrial cancer? And it's amazing that it took us this long to actually have this very simple trial with a very simple question, but that actually delivers answers so that we can actually know what we need to do. Because I think we're probably all doing different kinds of follow-up.
You are absolutely right. My personal interpretation of this trial, I agree with you, the question was very important, but the problem of this trial from my point of view is the huge number of very low risk patients. More than 60% of them were stage 1, grade 1 to tumor. So I'm not sure this data can be applicable to all the endometrial cancer population. The second bias is in the molecular classification of tumors. This trial, unfortunately, was lacking of these new classifications. I do not know exactly how we can manage this data in clinical practice. My personal view is that I will not do pap test anymore in this patient, and I would not require CA 125. This is the key message I bring at home after this trial.
Yep, and the importance of physical examination.
Absolutely. Alexandra, I leave you the stage. Tell us what are the news in ovarian cancer.
In ovarian cancer, it was more follow-ups on studies that have been previously published and presented. There was one study presented by Rob Coleman trying to define what are the characteristics of patients who receive a PARP inhibitor in the relapse platinum-sensitive setting and have exceptional benefit. So can we characterize these patients? And this was an analysis of the ARIEL3 study where patients were randomized after they were in response to a platinum to rucaparib or placebo. The investigators wanted to define what characterized those patients who did really well in ARIEL3 under rucaparib, meaning they had at least 2-year progression-free survival. That's about 20% of the populations in the study. And what did they learn from this in terms of their characteristics? One thing that's important is that people who do very well with maintenance PARP inhibitor, regardless of BRCA status, because I remind you that this study enrolled all comers, are those that have a very good response to chemotherapy. Those who had great benefit were those who had either a complete response to their platinum before going on to the PARP inhibitor, or such a response that you actually didn't have measurable disease. And that makes sense because we know platinum responsiveness is key to responding to a PARP inhibitor. Those were the clinical characteristics. In terms of the molecular characteristics, not surprisingly, patients with BRCA mutations, whether they be germline or somatic, had significant benefit. They also showed something that we were starting to know, which is that another mutations that are probably relevant are RAD51C or D mutations. In addition, some of the really great responders had mutations in RAD51C or D. One thing that was maybe a little bit surprising is that there's some data to suggest that BRCA methylation, so that's where you have very high levels of methylation of the promoter that leads to loss of BRCA protein, that could predict benefit. Well, they did not see it in ARIEL3. Some other studies have shown it. So basically, this is sort of telling us a little bit more about how we can understand which ones of our patients are going to benefit, particularly from a PARP inhibitor. And it's going to be those that responded really well to platinum. We know that, but it's an important information to keep in mind. BRCA mutations, of course, RAD51C and D. However, here we didn't see anything for the methylation. So that was the first PARP inhibitor sub-analysis. The second one is kind of a very practical question, and this was from the NORA trial, which was also looking at the benefit of a PARP inhibitor. Here it was niraparib after platinum and platinum-sensitive relapse. And the results of the study have already been presented, and it shows a benefit to niraparib compared to placebo. The question they asked is that we normally recommend 6 cycles of platinum-based chemo before PARP inhibitor. But not everyone had to have 6 in this study. Some could have only 4. So does it make a difference whether you have 4 or 6 cycles of platinum chemotherapy before you go on to receiving PARP inhibitor? And what they basically showed was that, well, actually, if you look in terms of PFS benefit of niraparib compared to placebo, patients who had 4 or less cycles of platinum seemed to benefit essentially as much as those who had more chemotherapy. So you don't necessarily have to give all the way up to 6 cycles. However, does it make a difference whether the patients have a complete or partial response? And there it does make a difference. So if you have someone who has a complete response after 4 cycles, they do just as well as if you go on to 6 cycles. If they have a partial response, you probably do better if you try to push the chemotherapy to 6. So again, very practical study here, but suggesting that, yeah, sometimes you probably could stop at 4, but probably do that in those patients who have a complete response at 4. If not, you should probably try to go ahead to 6. And so that was the 2 studies on ovarian cancer that I chose to highlight today.
Alexandra, I think that the message of 4 cycles of chemo are enough for patients to achieve complete response is one of the most important message of IGCS. You know that in our guidelines we reported that the 6 cycle of chemo is the standard of care in recurrent disease, but this trial seems to suggest something different.
Yeah, and I think it's important because we sometimes have our patients who have quite severe allergies, and this is reassuring to know that if they've had a severe allergy at third or fourth cycle and they're in complete response, we can feel comfortable that we can move on to the PARP inhibitor and spare them the risk of continuing on with a platinum. So it's a simple question, but it's an answer that could be useful for day-to-day practice.
You know that one of the key points is that the Japanese patient seems to be genotyping different from European. But do you think that this research can be applied also to European patients?
Yeah, it's a very good question. And I think we've been burnt before, and we should always be cautious with this because it is possible that certain chemotherapies may have more efficacy, certain treatments, just because the metabolism is different. So I think it's an important message and maybe one that we can try to answer with some of our other studies that were conducted around the world because we should be able to have this information.
Probably we can do the same retrospective analysis in our trial in second line to confirm or not this data. But I fully agree with you. This is an important message. What about cervical cancer, Alexander? In this moment, cervical cancer is on the stage in all our meeting.
It's about time. So yes, very exciting news for cervical cancer. So we already had a little bit of data from phase 2 single arm studies that cervical cancer benefits from immune checkpoint inhibitors. But as you know, in Europe especially, if we want to get a drug approved, we need a big phase 3 randomized trial, and this is what Empower Cervical 1 was. So this is a study for women with recurrent metastatic cervical cancer who have previously received at least one line of platinum-based chemotherapy. And these patients were then randomized, regardless of their expression of PD-L1, to either the standard chemotherapy, which is basically single agent chemotherapy, so topotecan, gemcitabine, vinorelbine. So that's standard of care, or semiplimab, which is an immune checkpoint inhibitor targeting PD-1, PD-L1 every 3 weeks. And this was a huge study. Over 600 women were randomized, and primary endpoint was overall survival, and secondary endpoint, progression-free survival. In terms of the characteristics of the patients that went into the study, I think there are a couple of points that are worth mentioning. So one is that majority were squamous cell, but the study allowed adenocarcinoma, which I think is important because some studies have excluded them. And they could have had one or more lines of therapy. And so about 40% of the patients in this study had actually received 2 prior lines of chemotherapy, and roughly half had received prior bevacizumab, and that usually depends on local reimbursements, whether or not that agent is available. And in terms of efficacy, so I remind you that the primary endpoint was overall survival, and overall survival was significantly improved with a hazard ratio of 0.69 in the overall population, okay, extending overall survival from 8.5 months to 12 months. When they looked according to histology, there was a benefit in the squamous cell population as well as the adenocarcinoma population, with hazard ratios of 0.73 for squamous cell and 0.56 for adenocarcinoma. So although it's unfair to compare, at least the adenocarcinoma didn't seem to benefit less for the immune checkpoint inhibitor. And in terms of the response rate, it is what was previously described in cervical cancer with other immune checkpoint inhibitors, which is basically a response rate of roughly 16%. The chemotherapy, I remind you, is not very efficacious in cervical cancer because the response rate was 6%. They did look at response according to expression of PD-L1, and the response was higher for PD-L1 positive patients at 18%, but they also had responses in PD-L1 negative with a response rate of 11%. So this is what you call a positive study with a benefit in terms of overall survival benefit. In terms of tolerance, overall, the treatment was well tolerated. I mean, single agent PD-1 or PD-L1 inhibitors are quite well tolerated with very few grade 3-5 toxicities. So this, again, is a tremendous good news for our patients. We've been waiting to have access to immune checkpoint inhibitors for our patients with cervical cancer. This, I remind you, is in patients who relapsed after platinum. But I know that in Europe, we're all eagerly awaiting authorities to examine these trial results and give our patients access to this drug.
Oh, Alexandra, I fully agree with you. This is really a practice-changing trial. You mentioned for sure the primary endpoint, which was overall survival, but there were some also signals in terms of PFS in this population.
I skirted that issue. You're absolutely right. Because so the primary endpoint was OS, which is why it's positive and they were able to show it. PFS, median PFS, there wasn't, numerically speaking, much of a difference, right? Because the median was 2.8 and 2.9. But I remind you that with immune checkpoint inhibitors, except maybe in melanoma, we have this tail effect, which is that there's a subset of patients who benefit. The median won't capture that, which is probably why in terms of numerical figures, you don't see a difference between the median, but that doesn't mean there isn't a difference in terms of the hazard ratios. And that's why you see such a difference in OS.
Oh. Thank you for this explanation, Alessandra. I think it is absolutely important to underline that even though median PFS, as you clearly explained, is not significantly different, the advantage, the efficacy of treatment was captured by overall survival advantage. And really, after we suffer a lot for negative results of ovarian cancer, finally, probably we identified in cervical cancer the population in which immunotherapy gained the larger benefit. Alexandra, a very quick and provocative question. So you know that during ESMO will be presented the results of 826 trial, which was the trial of pembro in combination with chemo with respect to chemo in the first-line metastatic setting. The trial had the opportunity to combine or not bevacizumab according to clinical contraindication, and we do not know the results of the trial for sure, but they were anticipated as positive by the company. So we have a positive trial in first line, where in any case we have the alternative of Bev, and a positive trial in the second line metastatic setting, where chemotherapy gave 6% response rate, as you mentioned. What would be your choice? Where we have to put immunotherapy, in your opinion?
I think we have to put it in first line. If, as you said, this trial is positive, which we have inclination it is. Now, the degree to which the first line study is positive, that's the information we're still lacking. But we know that patients with cervical cancer, the first line is really important because for a lot of our patients, there's such a deterioration in clinical status after first line that they sometimes are not really very good candidates for immune therapy anymore. They have low-grade fever, they're very inflammatory, and you know what? You look at these patients and you know they're not going to respond to the immune checkpoint inhibitor. So that's the first thing. So you want to use it first. The second thing is that single agent, all the studies of single agent PD-1, PD-L1 in cervical cancer give about 14-15% response rate. Combine it with anything, an anti-angiogenic, a vaccine, whatever you want, and your response rate goes way up. So the first line study, it's with chemo, potentially with bevacizumab. So I think we're hoping we'll get even more, maybe some synergy there that could really not only mean they're fitter, but it's also more active because it's given in combination.
I agree with you. We will see also the results of the two ongoing trials combining immunotherapy with chemoradiation in locally advanced disease. The endpoint is to cure patients in that setting, but in absence of this data, I agree with you. The first line is the preferred set in which using treatment. So, Alexandra, thank you so much for this great discussion. This concludes our discussion of the key clinical studies for endometrial, ovarian, and cervical cancer presented during the virtual IGCS 2021 meeting. Thank you for listening. We hope this discussion was useful for your clinical practice. See you soon.
See you soon. Bye-bye.
Thank you very much, Dr. Lorusso and Dr. Leary, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, 2021 global conference coverage and update on the clinical development across gynecologic malignancies, and to download a highlights slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, Thanks for listening.